problem. For this, I think we always see toward government to make some policy which can help people to make it easier, this connectivity issue. Then the problem of engagement and trust. We all know that in psychological help or in sessions or therapies, treatment of psychological problem, the big challenge for a therapist is the challenge of the engagement of patient. How we can engage our patient for all the therapy sessions, because there is a withdrawn symptoms and patient visit once to therapist that takes a long gap, and it becomes difficult for caregivers as well to take him or to convince him to visit again to therapist. So when we are on digital mental health care, so it will be a great challenge for therapists that how he will keep engaged to this patient or person who is taking help. And secondly, how his trust will be maintained, because confidentiality and privacy is an important factor in mental health care. So online services may raise this question. And then the quality and validity. Quality and validity is on both sides, not only on the professional sessions or techniques or usage of strategies, but also the usage of instruments or tools. Because the professional training quality is important that we can make some sustainable uniform policy at Pakistan level where professionals can take trainings. We all know that how much this chaos is there about clinical services and you know about these therapy works, standards and things like that. So it's very important that digital mental health care will need a lot of monitoring by our government institutes, that quality can be maintained. Then indigenous tools which can be used digitally, and how the validity of these online digital tests will be standardized, how its efficacy will be maintained. So it takes a lot of research for that. Then coming toward the monitoring and efficacy, once you can start digital mental health care, it's not so difficult to start any new program following the global programs, but how will we maintain the efficacy of that program, how we will monitor these things, the evaluation strategies, who will do this, because we don't have any forum where we can, even our professional psychologists can get registered. We don't have any such type of organization. So it's a big challenge for Pakistani professionals. Then professional trainings and expertise. We do have training models from West for this digital mental health care monitoring models, but we need to indigenize those models, because our demographic and geographic and political and social situations are different. We have a number of factors which are very different from West. People in West may not be aware the crisis of load shedding, protests, dharnas, rallies. So these are the things which are very much indigenous, and we have to deal with those things, and how our trainings and our expertise will not be impacted by these local issues. So these are few challenges. Again, this is a very big area, and we can face many more challenges as well. But these are actually major categories of challenges that we may face when we will enter a digital future for this digital mental health care. Moving forward, the future opportunities. What can we do? Because we cannot stop our journey here thinking that we are facing a lot of challenges. We have to get some solution as well. So for those solutions, I think the number one thing is that if we want to compete the global world, then we need to move from apps to an integrated operating system of care. For digital mental health
चलो मैं
care,
कर देना
if we,
फोन कर देना
instead of making
कितनी बजे वाला
independently
टाइम
some
कितनी बजे वाला
apps,
टाइम है
if we can work for some integrated system,
सवेरे
and this operating system can be uniformly
अच्छा
used by
रात को
all
करना वैसे
professionals and can be monitored by some
चलो सवेरे
institute.
बिजनेस क्लास हो गया
Then we need to develop tools that are highly
ठीक
effective and
करे ना
easy. For digital mental health care, we need to make the instruments for assessment, diagnosis, and for data collection and for need assessment. And then we need to establish the validity of these things as well. Then how can we address inequalities? As I told you that our geographical and social and demographic practices are very different, we are not even providing physical health services equally to all the
सर
segments of
वालेकुम
community.
अस्सलाम
You can see that our
सवेरे
qualities of
5:20
health services are even
बावलपुर to लाहौर
different
बिजनेस क्लास
for
तक कर दो
gender. The services we provide to boys may not be available to girls in all the areas of Pakistan. Then we do have
हाँ
some marginalized communities in Pakistan. Like these can be people living in slum
वो
areas,
टिकट वापस कर रहे हैं उन्हें
immigrants.
1600 रुपये दिए
We
थे
have a
वापस
large number of
1600
migrants in Pakistan. And then we do have people
हाँ
like
वो कर दी
these
ने
days flood
ते कल दी
affected, they
बुकिंग
are
कर दो
moving
वाल
from rural to urban areas. So we
कल
don't
दी
provide
बुकिंग कर दो
equal
5:20
services to all the
5:20
segments of life.
ते
So
बिजनेस
how do
क्लास
we address these
शहजाद
inequalities
ना
in
है
digital mental health services? So we
शहजाद
need to
चुगता है
work on this.
ठीक ठीक
This is an opportunity for people who want to work, for those organizations who want to work for the inequalities or injustice things. Then how we will build trust in digital tools. For building trust on digital tools, I think we need to make some system that can give this operating system. I don't know how safe it will be, but at least we can try that we make digital tools which are safe and which actually tap the actual problem among people. Then choose risk and protect users from potential harms. Safety management systems are very important for technology. I think we all know that we need to develop some safety management systems. We need to educate our people and young people especially that how they can use their gadgets safely without losing their information, without losing their data. For this, I may suggest at this forum that we need to work on cyber psychology. We need to introduce cyber psychology as a new area of psychology in all over the Pakistan, in all over the universities. So this can be a good start that if we work on cyber psychology, we can we can spread awareness among masses that how we can control the issues related to digital
मेरा
mental
लिखो
health
चाहे
care
आपने
and
लिखो
how we can reduce the challenges and
मेरे को
harms.
भेजो चाहे मैसेज 0300 000
When I have prepared my presentation, last
000
time I went through this model.
272
This model is actually ecosystem
400
wide recommendations to increase digital mental health access and quality.
400
I read this article and this
400
was
शहजाद
very useful because these parameters of this model
ठीक
are
है
actually
ठीक है 6 नंबर
generalized
6 नंबर सर ठीक है
parameters,
सर
and we can easily
ठीक है
adapt
मेहरबानी
these parameters as per our indigenous needs. In this model, you can see that for future, if we want to work to use this digital mental health care services properly or properly functioning in Pakistan, then the number one step that we need to take is the real world evidence. First of all, we need to assess we need to go test the
वालेकुम सलाम।
reality,
6 नंबर सीट
what
है,
actually is needed.
सवेरे 5 बज
Are
के 20
we
मिनट
really needing this
6 नंबर
digital
सीट।
mental health care services or not?
मोबाइल नंबर मैं
So we
अपना
need to
लिखवाते हैं,
track
मैसेज आवे सी
the
मैं तो सेंड कर
reality
दी।
and then we can move forward. Then educate providers and consumers. This is very important. We cannot start any new thing until or unless we change the mindset of people who will be developing these programs and who will be using these programs. So for consumers and developers, for both, we need to educate them through awareness programs, and we can change their mindset and we can convince them that how important these things are for us. Number third step is adaptive interventions to optimize care. As I have earlier said that we cannot follow any model blindly taken from Western literature. We need to work on our indigenous needs. We need to take care of our indigenous requirements. For this, we need adaptation of the interventions and strategies. Then next step is to create for diverse population. As earlier said that we need to include all the population or segment of the people so that equally people can get access to every opportunity. For this we need to include diverse people in planning these digital programs and implementation of these programs. Then the last but not least is the trust building. Once we will start these programs, then we need to make sustainable maintenance of these programs so that we can build trust. If we will not continuously work on these programs, we cannot build the trust of masses, and consumers or people may lose credibility of this digital world, and we cannot actually complete the digital mental health care as the global world is doing. So I think from these suggestions I will thank you again, and if you have any question, please post it. Thank you very much.
Thank you so much, ma'am, for providing such a comprehensive overview of challenges and opportunities regarding mental health in digital future. Now, I would like to call our session's chair. First of all, I would like to call Professor Dr. Rabia Khawa. She is serving as the chairperson, Department of Psychology, Government College University, Faisalabad. Other than that, she has a number of publications on credit. Her areas of expertise are emotional recognition, effective neuroscience, cognitive psychology, child and adolescent psychiatry. Ma'am, please come on the stage. Our second session chair is Dr. Abid Rashid Gill. He is serving as the chairman, Department of Economics, Islamic University, Bhagalpur. He is the director of the Green Campus Program, IUB. He has completed his PhD in Environmental Economics from University of Utara, Malaysia. He has published many articles on environmental issues, and his many publications are published in reputed journals. So please come on stage and grace us with your presence. Now I would like to call our first presenter. Her topic is mental health burden and quality of life among Malaysian caregivers in patients with end-stage renal disease. A cross-sectional study by Nora Hayati. Ma'am, please come on stage and give your presentation. Ma'am, Nora Hayati Ibrahim. Okay, so I guess ma'am will join afterwards. So our next presenter.
Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Okay, my name is Nurhayati Ibrahim from National University of Malaysia. Okay, my topic today is about mental health, burden and quality of life among Malaysian caregivers and patients with end-stage renal disease. This is a cross-sectional study. Okay. Okay, when we talk about mental health, usually we focus on normal person, yeah, more normal population for youth. Yeah? But what about the patient, especially patients who are who have a chronic illness? So for my study, I focus on end-stage renal disease, kidney disease. So as we see that is irreversible and life-threatening condition, which result in the permanent loss of kidney function and in need of renal replacement therapy, whether you use hemodialysis or what we call peritoneal dialysis. So peritoneal dialysis, you can do it at home, but for hemodialysis, you have to go to the center or the hospital to do the dialysis. Okay, the impact of dialysis is we can see that it can impair the physical, mental, and emotional well-being of patients, but also for the caregivers also. Yeah? And then my study just involved informal caregivers. This is informal caregivers. The terms of informal caregivers is focused on people who provide care to the patient and supporting their needs and a physical, emotional, and social level without any reimbursement for their care. And then, okay, we go to the, problem statement. Why I did this kind of research? Actually, there is a lack of dialysis study focusing on patients undergo dialysis and their caregivers in Malaysia. Usually, many study, especially for chronic illness, they are focusing on patient only. But in this study, we focus on patient and their caregivers. So dialysis study related to psychological well-being and quality have been conducted in overseas such as in Japan, Brazil, Jordan, Greece, Pakistan, and Saudi Arabia, but not in Malaysia. So most of the studies related in Malaysia were conducted on end-stage renal disease population, overshadowing the mental and physical well-being of the caregivers population. Okay. Okay, the purpose of this study is to examine the mental health, burden, and quality of life among Malaysian caregivers and patients with end-stage renal disease. Okay, this is the cross-sectional study purposely recruited participants from 4 government hospitals and 8 private dialysis centers in Klang Valley in Malaysia. And then those who consented answer the informed consent. So they will answer the 36-item short form for quality of life, to measure the quality of life. Zaire burden interview for burden, to see burden for caregivers, but for patients we use self-perceived burden scale. So different burden scale for patient and caregivers. And then we use a general anxiety disorder to measure their anxiety and the patient health questionnaire 9 for depression. So data were analyzed using descriptive statistics, Pearson correlation, and independent sample t-test. Okay, and then this is inclusion criteria for patient, and then I think no need to read it, and then you can see it from the slide. And then we move to demographic. This is the result of my study. This is a descriptive result. You can see that the majority of the participants were female of and Malay ethnicity with mean age 46.5. And then the patient, most of them is age 40 to 49 years old. And then the second population is, the second young age group is 30 and to 39 years old. This is the second highest age group that involved in our study. Okay, this most of that, 90% of my sample from, actually the sample is involved 120, and 60 patient and another 60 is caregivers. Okay, then this is a psycho well-being. You can see here that patient self-perceived burden, they shows that about 88.3, they have a high self-perceived burden. This is from the patient perspective, and then from the caregivers perspective, we show that caregivers care burden, they have about, the majority have a minimal to moderate burden, and then 90.7 moderate to severe. Okay, and then psychological well-being, this is the anxiety. The most of them is minimal anxiety, but they have 3.3%, they have a severe. And then for depression, you can see 6.7 moderate to severe depression, moderate to severe. And then this is for caregivers. And then for caregivers, you can see that for patients, we don't have severe depression, but in caregivers, we have 1.7%, they're having a severe depression. So, and then this is a Pearson correlation to see the correlation between quality of life with burden, anxiety, and depression. It shows that quality of life, self-perceived burden, care burden, and anxiety and depression have a negative significant correlation with the quality of life in physical and also for the mental. And then this is for my last result is about the comparison between patient and caregivers regarding to the quality of life, anxiety and depression. However, not a significant difference between patient and caregivers. So, and then I have another 1 minute. Okay. So, as a discussion, you can see that self-perceived burden, care burden, anxiety, and depression was significantly negatively correlated with physical and mental component of quality of life among end-stage renal patient and their caregivers. This is in line with the study by Additional and 2021 and Pure, which is that care burden, anxiety, and depression was statistically negatively associated with all domains of quality of life among caregivers of dialysis patients. And so as a conclusion, caregivers, based on the result, anxiety, depression, and burden remain as important factor associated with the quality of life of caregivers and patients undergo for dialysis. Therefore, this is crucial for healthcare authorities and policymakers in Malaysia to mitigate the distress felt by the caregivers and end-stage renal disease patients throughout the target intervention and improve their overall quality of life. Actually, this is part of my study. I got grant from government in Malaysia, and then I presented. What I present is just half of my study. This is a preliminary study only. Actually, we already managed to get 120 patients and 120 caregivers in the real study. So, but now we still doing the data analysis. But I think that's all from me. Sorry because you have to wait for me because I have something to do outside to do just for the poster presentation. That's all for me. Thank you very much for your kindness to see my presentation. Okay, thank you very much.
Thank you, ma'am, for your presentation. Now, our next presenter is going to present an association amongst celebrity worship, dysmorphic appearance, concerns and depression in young women by Annabella. Kindly come on stage.